Thank you, Jean. Thank you, Pascal. Because we are late, I try to condense my presentation as much as I can, despite the number of slides. If you look at the international prevalence studies and outcomes in the worldwide intensive care units, you may realize that wherever you go at the very end, where the major infections are represented by the classical categories of gram-negative, gram-positive, and fungi infection. One of the first messages is that if you look at the various pathogens, they do have a specific interaction with our immunocells, having the possibility of a combination at the level of these dendritic cells and activating the inflammatory cascade. In this quite busy slide, it is shown how, looking at the different receptors on the surface of these cells, the activation mechanisms through some transmitters within the cells activate, for example, the NF-kappa B, which is one of the most popular, is capable to translate the message coming from the combination at the level of these cells into the nucleus for the production of a number of mediators that indeed represent the major actors of the septic conditions. And indeed, what these kind of activations produces is a clinical pattern that is quite well characterized also in the new definitions of sepsis, and that is focused specifically on the hypoperfusion of the different organs and the derangement at the cellular level. The host response to the organ damage is articulated in two main groups: the pathogen-associated molecular patterns and the danger-associated molecular patterns, which represent, both of them, the interaction between the agents and the host. And if you look at the number of mediators and cells that are implicated in these responses, you may see that in the end, it translates into a balance between a pro-inflammatory response and immunosuppression, depending upon the different conditions. The amazing thing that the interaction of all these two patterns is at a cellular level, at an organ level, translate into the derangement and organ failure that is driven by different local mediators that are more characteristic for certain areas. But as soon as we look at the inflammatory dysfunction and the multiple organ failure, you can see that the dysfunction that pertain all the organs doesn't spare any of the organs. You go from the endothelial dysfunction up to the neurological dysfunction in a multimodal phase that is indeed induced by several conditions and damages, not only infections, because also the trauma, for example, is capable to activate this inflammatory response. For sure, one of the things that we may just clearly stress is that looking at some of these mediators, namely the cytokines levels and the severity and the mortality risk that is related in this context, you may immediately realize that as soon as you have a higher level of these cytokines, it may be the case of the IL-6, for example, the concentration of these mediator goes to a higher mortality rate in the most severe categories of patients represented by septic shock. Then there is this balance, the immune activation and immunosuppression. The real matter is that as soon as you look at the number of studies that has been done so far, the final results are quite discouraging and I would say also frustrating. A long list of negative results, and then it poses some problems both on the inflammatory and immunomodulation part of the story. However, one thing that has been attended with I would say positive and negative results is just looking at the story and just attacking the different agents through a different concept, which is the blood purification in order to remove these mediators or these activating substances and block the inflammatory cascade. And if you look at the meta-analysis that has been published some times ago, you can see that there is at least a trend or positive results in favor of this specific approach. The extracorporeal blood purification may act in a different way. You can just having the capabilities of adsorption or removal depending upon the characteristics of the different membranes and acting on the immunohomeostasis just favoring a better balance. Which are the mechanisms of extracorporeal solute removal? Fundamentally are those that classically are recognized for dialysis, the diffusion, the convention that indeed go together with the membrane characteristics, and the absorption that indeed is represented a different kind of mechanisms. If we want to do or we try to attempt an immunomodulation of the septic cascade to the extracorporeal approach, you have to take into consideration several aspects. Timing is important, early versus late, and in generally an earlier approach may be beneficial. The target, the pathogen patterns and the removal of the inflammatory mediators go together. And the therapy may indeed imply the transmembrane removal together with the absorption. The first category of this kind of blood purification, let's say, it's the use of non-selective inflammatory mediators removal. That is related in part to the transmembrane flux and absorption. The cytosorb is one of those, and because of the characteristics of the membrane, the porosity and the permeability of the membrane, as you can see in the lower part of the slide, the number of substances that can be filtered is indeed quite huge. And the real problem, as soon as you see this kind of substances and these kind of therapies, is not the capabilities of removal of the substance, which is quite effective in doing so, but the impossibility of having indeed a clear-cut selective removal of them, and in certain extent, as happens with the dialysis, you may remove also beneficial mediators as well as some of the therapeutical substances we deliver to our patients, such as the antibiotics. And the membrane cutoff is, in this kind of approach, an important element. We can use also a different concept, which is the high-volume hemofiltration, when we have patients with a septic acute kidney. If you look at the meta-analysis, you in general address as a major point the mortality, and looking at the secondary outcomes represented by the restore of the hemodynamic profile, the length of stay, or the onset of adverse event. And this meta-analysis show that there is a trend that favors the high-volume hemofiltration, even though a clear-cut benefit, which is significant, has not been demonstrated. However, I think that one of the major elements is also related to the characteristic also in this case of the sieving coefficient of the substances and of the membrane. Another way of approaching this concept is just to use a coupling the filtration and absorption, as in shown in the slide, when you have a sorbent membrane together with the characteristic hemodiafilter and plasma filter. And the effect, however, are indeed not very positive, and the capability of improving the survival is indeed substantially the same whatever you do, even though the hospital mortality addressing specific categories of efficacy related, looking at the higher plasma filtration rate, seems to be more beneficial than other situations. If you look at the highly selective absorbing membrane and sorbent, you have a number of them, and with different characteristics, and all of them have the possibility of removing the mediators that I have addressed so far. Another story regards the selective inflammatory removal, and then you have a concept of absorption over the membrane. And this is the case of the endotoxin, for example. You know that the endotoxin links and is bounded to specific surface receptors of the dendritic cells, such as the toll-like receptor 4, and as happens for other kind of agents, are capable to activate dramatically the inflammatory cascade. The concept of having a filter that adsorbs is related to the utilization of an antibiotic, and all the antibiotic, which is the Polymyxin B, tightly bounded to the fibers of these cartridge and not liberated into the organism. So the action of this kind of ancient antibiotic is not against the agent, but the capability of absorb tightly through ionic and hydrophobic forces the endotoxin. And if you look at the meta-analysis again concerning the blood purification, that tells us that there is a certain positivity of the blood purification techniques for treating these patients, you may realize that large part of the beneficial effects that have been achieved were related to the use worldwide and in several studies of this kind of cartridges. There is a randomized trial that was conducted in Italy on the Polymyxin B hemoperfusion that was positive in terms of reduction of the endotoxin burden and assessment of the hemodynamic stability. There was a positive also in terms of mortality, but that study was not addressed and conceived in order to demonstrate any difference in mortality. There was a negative study, that was a French one, that has as a major difference characteristic having enrolled less severe patients and with not identical and comparable techniques respect to the one that we use in the other trial. But certainly we can also stress how this kind of specific hemoperfusion has also the possibility not only to bound the dendritic cells activated together with the endotoxin and the endotoxin per se, but also inactivates the pro-apoptotic factors that are circulating into our blood. I want to address this study that is going to submit it for the publication, which is the largest study so far on this kind of filter conducted in North America in over 400 patients, and where was the intention of selecting septic patients with measuring the endotoxin level and all having endotoxin activity above 0.6 and whose multiple organ dysfunction score was above 9. So a very specific characteristic of patients, all of them very severe, in order to see if the technique could have been really effective. Well, this is also a very complex study because it's a really randomized, double-blind, placebo-controlled trial, and all the doctors were just blinded about the techniques, and there was a fake extracorporeal circulation and a fake catheters, just in order to avoid any possibility that the doctor in charge could know that. Those who were aware about the randomization were only the nephrologist. The primary efficacy endpoint was the mortality rate at 28 days. And then there were a number of secondary endpoints, including the change in organ dysfunction, in main arterial blood pressure, in the cardiovascular index, and the change in renal function. At the end, we enrolled almost 400 patients. 212 were in the polymyxin group and the other one in the sham group. I cannot give you all the final results because the paper is under submission, but for sure, all these patients in the study had a high level of endotoxin. And in the next few slides, I will come back to this concept because it is important to understand what is the reason why this study was substantially negative. Indeed, the final intention to treat population with a multiple organ dysfunction score above none didn't show any difference in mortality, because in the placebo group, the mortality rate was 44, and in the polymyxin group for 43.75. If we move to the per protocol analysis, especially for the most severe patients, there was a benefit in terms of 5%, but this is a trend because it's not significant. The safety analysis showed that there was a very safe application, and we had much less clotting events respect to the study, the French study I alluded to before. But I think one of the most important elucidating finding that we had with this study was the capability to better understand the implication and the role of endotoxin and why at times we may be not so effective through our therapies. Indeed, there is a measurement accuracy that should be taken into account, and the burden of the endotoxin. There was an experiment done on 20 healthy volunteers where testing the aliquot of their blood after having challenged with a small amount of lipopolysaccharide, which is the essence of the endotoxin component, there was the possibility to, in a way or another, compare the activity measured through the Limulus test, which is the endotoxin activity test, and the amount of lipopolysaccharide present into the sample. And one of the things that was that emerged and in a way or another elucidated some of the concepts that are behind regard the fact that the high measurable portion of endotoxin, when we can compare the endotoxin activity assay with a in a way or another true concentration of endotoxin, is in the range between 0.6 and 0.9. Above this range, the amount of endotoxin can be very huge, very large, or relatively large. If you look at the volume of blood, and you may to the volume of blood and distribution into the interstitial fluid, you may get for activities that are above 0.9 even more than 50 micrograms of endotoxin, which means very, very large dose, very large concentration of endotoxin, much more difficult to be removed. So the endotoxin kinetics is linked to various situations for the removal, the production, production and the distribution into the blood and the interstitial fluid, the source control, and the removal pathway. The capability of the colon is another issue, because it works well until a range of, let's say, 10.7 micrograms of lipopolysaccharide, but it is evident if the amount of this of this endotoxin exceed this threshold, the capability of the colon of removing this large amount of endotoxin, it is much less. And this is one of the reasons why, at least in this sample, because we had a huge number of patients whose level of activity was above 0.9, we may just focus on a population where the production of endotoxin was very, very high. And this multimodal pattern and behavior of the patient course may explain also why in the physiological evolution of these condition, this kind of approach may be not effective enough, because it's capable to remove the amount of endotoxin, but for instance, if the source control is not perfect, this may continue in producing the endotoxin level, and then also the second run of Polymyxin B filter is not capable to eliminate completely, because there is the source control that is still there. So just as a conclusion, I think that we do have a number of challenges: population, target, timing of intervention, and we still do not know a number of things, and probably the future knowledges and the development of science in the ambit, in the environment of genomics, transcriptomics, proteomics, and metabolomics can help us in better identifying the genotype and phenotype of our patients. So, which are the final conclusion? That sepsis, as known, develops from a non-physiological inflammatory response to a pathogen. Then the dysfunctional inflammatory burst is modulable by drug administration or extracorporeal removal of these host and pathogen mediators, even though, even in this case, the results are not very encouraging. And there are a number of devices that can help, but please, the message is that you have to consider all these devices not as the solution of the story, but as one of the small brick or the small complementary therapy that can help the fundamental approach to these patients that goes together with an adequate antibiotic therapy, the source removal, and so on. So we have to see if the future knowledge can help us in better addressing the population, the time, and the way to remove it. Thank you.